I'm Andreas Gomoll. I'm an orthopedic surgeon. My subspecialty is sports medicine, and I work in New York at the Hospital for Special Surgery. When people think about arthritis, they mainly have this picture of sort of an older person, walk slowly, hunched over, using a cane. But I see a lot of patients who are in their 30s and their 40s, and they have arthritis. There's something called the osteoarthritis or OA treatment gap. And what that means is, unfortunately, I'm in my mid-50s, our joints wear out like anything else wears out. You can do bracing, you can do injections, but oftentimes we end up spinning our wheels and the patients aren't really significantly better. That's where MISHA comes in for patients who have medial compartment degenerative changes, and they've tried and failed conservative management, and now there's a new option. MISHA is sort of a mini car shock absorber. The way this works is very similar. By essentially absorbing load that would otherwise go through a damaged area in your knee. As an adult, I would say there's no age restriction. You can make a case to do this in a young person who has arthritis, but you can also make a case when you have an older patient and you're simply looking for a less invasive intervention, something that has less blood loss, for example. Patients don't only want to know, will I get better, but how much better do I get? And how long does that last? And that's the beauty of now having 5-year data. Most patients were off crutches within 2 weeks, which really is a big deal for everyday life. Patients said their pain had a reduction of 50% by 6 weeks. That's remarkable because usually surgery makes people worse. At 5 years, still 96% of patients had this clinically meaningful reduction in pain, which is gigantic, more than I've seen in most other studies. Patients shouldn't only feel better, but you also want to see that they move better, that they function better. If you just sit on the couch, you probably don't have much pain. So function is really an integral part of these outcome studies. And this is one of the first studies that really used these dual endpoints, where to be successful, patients had to really win both. And one also important aspect to know about MISHA is that you don't have any activity restrictions. So for example, if I do a knee replacement in someone, I would tell them, try and minimize high impact activities because we worry about mechanically damaging the replacement, which can shorten its lifespan. With MISHA, we haven't found that to be true. And one of the beauties, even if it does fail, because this is a procedure that adds to the joint, it doesn't take anything away from the joint. We're not cutting anything out. If it fails, we can take it out. And to me, at least, that's very reassuring. So I think the most exciting thing about the 5-year data is that there is 5-year data. It sounds silly, but there are a lot of things that come on the market and they're not really supported by long-term data. And I think as an orthopedic surgeon or any physician, this do no harm is probably one of the most important things. Whenever new technology hits the market, new implies untested, unproven, no known future outcomes, and that's really not the case here. So the first predecessor implant, that was implanted in 2008, and I've been initially just from the sidelines, but then through multiple clinical trials, deeply involved, been following this for essentially 10 years. And it's nice to see something from the early planning stages through clinical trials, through FDA approval, and now in clinical, almost daily use. I'm Dr. Andreas Gomoll, and I moved to MISHA.